Well, welcome everybody to the NHS public meeting. I should just start by saying that Aradazi has had to give his apologies. He's working on this REACT study at Imperial on COVID. Are there any declarations of interest?
David, you should probably just record, I'm not sure it was in the last board meeting, my appointment as the interim chair of the National Institute for Health Protection.
Thank you, Dido. Sorry, I should have. Yeah, thank you for that. Can we just approve the minutes of the last board meeting? Yes. Thank you. Well, the first item is for Simon, the Chief Executive, to give us an oral report. Simon.
Thank you very much, David, and afternoon, colleagues. We are obviously going to be talking specifically this afternoon, amongst other things, about where we stand on the coronavirus response, but also more widely the ramping up of services across the whole of the NHS. We said at the end of July when we spoke that there was a window of opportunity between July, August, September, October before we head into the winter and concerns about a possible second COVID wave, in which it would be possible to fire up all the cylinders across the health service. And as you'll hear from Amanda, that work is progressing well. However, it is also the case that, as has been now publicly reported, we are seeing increasing coronavirus cases in several regions across the country. And as we speak, we have just over 2,000 coronavirus positive patients in NHS hospital beds. That is 4 times more at the end of September than at the beginning of September, although of course that is still thankfully substantially fewer than the 19,000 peak acute inpatient beds that we had for coronavirus patients in mid-April. So across the health service, detailed work to envisage and to look at escalation plans against different amounts of coronavirus pressure. We will again discuss that a bit later this afternoon. And in addition, we are also gearing up for the winter season, flu vaccinations, staff support that would be happening come what may. So this is going to be a very pressurised 6 months for the health service, coming off the back of what has also been an incredibly pressurised 6 months. And as we get into the discussion this afternoon, I know that as always, we will want to pay particular thanks to our frontline staff across the health service. And in that regard, I think the last thing I would just say is that, of course, this marks the beginning of Black History Month, and that is always a timely moment to remember the contribution that Black, Asian and minority ethnic members of staff across the health service have made, not just now, but right from the get-go. And the Windrush generation famously were part of the generation who helped nurture and sustain the NHS from the beginning. Wind the clock forward 70 years, we can see through the impact of coronavirus the differential impact that inequality, including race-based inequality, is having not only across our workforce but across our communities. So I think at a future meeting we will take the opportunity to hear the work that the new NHS Race and Health Observatory is embarked on, together with the wider programme of work that NHS England and NHS Improvement are leading. I think that's probably enough just to get us started, David, but as always, happy to take questions.
Well, Simon, maybe I can ask you one question. I mean, if you cast your mind back to early March and the state that the NHS was in at the time, and sort of trying to compare that with where we are today in terms of our readiness to face up to what may be a second wave of coronavirus, how would you characterise the NHS sort of state of readiness at the moment?
Well, I think there are several things that are different than the position in mid-March. The first, of course, is that there is more community surveillance and testing, so that there is a better appreciation of the extent to which coronavirus is spreading in the community. And what follows from that is that there is a better understanding about the particular pressures now in the northwest, parts of the northeast, some parts of the Midlands, some concern growing in northeast London, whereas frankly in February and early March the absence of that testing infrastructure meant that it was not appreciated by the public health epidemiologists how much coronavirus there was in the population. So I think the first thing to say is we've got a better surveillance system as a country than we had 6 months ago. The second thing to say is that in terms of the NHS, obviously a lot of the rapid mobilization that happened, whether that was in securing ventilator supply, creating buffer capacity, redeploying teams, creating COVID safe environments for care of non-COVID patients. That work is now well established, and we have available to us were there to be a continuing increase in the second wave. And I suppose the third thing to say is that the clinical insights around effective treatments have advanced quite considerably since then, not least as a result of the randomized controlled trials that are being run out of this country, and which have produced the two first evidence-based treatments that reduce mortality for COVID, and many others in the pipeline as well. So, on those three fronts, both in terms of surveillance, in terms of capacity, and in terms of treatments and clinical practice, we are in a better place. But none of that should detract from the fact that were we to see continuing growth in coronavirus coming alongside the winter pressures, that would obviously be very undesirable from a public health point of view, from a point of view of excess mortality, and from the point of view of impact on other NHS services. So it is vitally important that the measures that are being set out by government, that the test and trace operation that Dido is leading, continue to play their part alongside the actions that we, the people of this country, ourselves take to reduce transmission between people.
Thank you, Simon. David Roberts.
Just to build on that answer, Simon, I'd be interested in your, before we go into the sort of the next agenda item, I'd be interested in your perspectives on the state of the workforce, because for all the plans and everything, it's fundamentally based on the on how our people are, and they've done, as you rightly pointed out, an incredible job. But we're now facing into a number of months of similar challenges, hopefully not as significant as last time. And I'd just be really interested, as you think about the various sort of levels and layers of the NHS family, how well supported and their sort of state of readiness, if I could use that term, for what's coming ahead of us. Thank you, David.
Well, I think there have been huge pressures across the health service, and that's been experienced, very acutely, obviously in places such as critical care, intensivists, anaesthetists, thoracic medicine, many other specialties, and lots of other people who pitched in. But it's also, frankly, been experienced in primary care, in mental health services, where we're seeing more people with mental health needs coming forward. The community health services are obviously a vital part, given that the majority of people with coronavirus aren't sick enough such that they require hospitalization. So I suppose a way of responding to what you're saying, David, is that we went in February, March into the first phase of the pandemic with people who'd obviously were already under pressure having come out of winter. But that is doubly so now, because the last 6 months have been highly stressful for many colleagues. So there are various things that we're doing nationally and working with employers locally on. Obviously, the health and well-being support in the workplace is vitally important. Frankly, ensuring that we've got as many people as we can to help, and that's not just now, but it's a sense that others are going to join. Ruth might talk about the very substantial upsurge in interest in joining the nursing profession that we've actually seen on the part of young people on the back of the last 6 months. Applications and acceptances to undergraduate nursing degrees, I think are, we're likely to blow the barn doors off. I think we're going to have a very, very strong intake. So, that is all good news for the future, but doesn't deal with the immediate pressures of the here and now. But maybe Ruth and Perena, if she's on, would like to come in as well.
Ruth, would you like to comment on from a nursing perspective?
Thank you very much, Chair. And just to build on what Simon said, nurses, midwives, care staff have worked extraordinarily hard through this pandemic and been very proud of the way that they've stepped forward with their huge clinical expertise and experience. One of the things we've noticed, though, is that whilst we've been able to retain more of our staff, which has been fantastic, we've been able to recruit more staff, and our vacancies are coming down each month. Our healthcare assistant vacancies have almost halved. All that is really important. And of course, we've started to welcome our international colleagues coming over, and I'm really pleased the work that Duncan has been leading with that with me. But of course, the psychological support that our staff have needed, not just those in critical care, but those people that were in theatres that went to the aid of critical care, those people in mental health organisations, those people in community. So working with Perena, of course, talking and thinking about what extra support and psychological support that we can give our staff. Well, as Simon has said, working with Mark Radford and HEE, we've seen a huge increase in the number of people wanting to become a nurse. If you think about people accessing the interest in health careers on the internet, a 210% increase in the searches on how to become a nurse, which is fantastic. 43,000 people wanting and applying to be a nurse. And Mark been leading the piece of work to not just focus on the undergraduate, but the postgraduate, people coming into our profession, the nursing associates converted into registered nursing, and of course what HE are doing around a blended degree. So I'm hoping by the time the figures finally come in that we'll see a massive increase in the number of people coming into our profession, maybe even the most we've seen for over 20 years. And that would be just a delight.
Thank you, Ruth. I mean, Steve, do you have a comment from the sort of the medical side, the doctors side?
Yeah, well, I would really just emphasise what both Simon and Ruth have said. Staff clearly did a magnificent job in the spring and into the summer, not only in making sure that patients with COVID were treated when we had that peak, but also that they also kept other services going. Cancer services, 85% of cancer treatment continued between March and July, but they also worked with cancer patients where it wasn't the right thing to do to continue treatment, perhaps patient preference. So there was a lot going on that wasn't COVID during that period as well. More than 200,000 people, for instance, treated for cancer during the peak of the pandemic. I'm sure staff are looking at the headlines and the news, and they will have concerns about increased numbers of COVID patients, and I'm sure there is some trepidation about going into a second wave. But I'm absolutely confident that, as always, our NHS staff will step up. They care passionately about caring for patients, COVID patients, and all patients, and they will do what's required. But as Simon said at the end, this is really a responsibility for everybody. I said many times in the spring that it was the efforts of all of us as citizens, the public, in reducing our contacts, in maintaining social distancing, that actually allowed our staff in the NHS to do. And now hasn't changed, and our staff think about social distance rules. They reduce contacts where they can, and we all play a part in stopping this virus spreading.
Thank you. Ian, I'm going to ask you to come in, then I'm going to ask Emily just on the procurement side, particularly around PPE, just to make a comment. But Ian, over to you now.
Just to add a comment on primary care, picking up on Simon's point. So primary care is now as busy as it was pre-COVID. We are back to basically over 6 million appointments a week. And this, of course, is in a context of the COVID standard operating procedure and all of the IPC controls, which have some kind of productivity hit on primary care. So I just really wanted to pay tribute and recognise the busyness of primary care now, particularly preceding the winter flu season. All the more reason why primary care networks and GP practices are busy hiring additional staff, and why we collectively with our partners need to redouble our efforts to hire extra GPs.
Thank you, Ian. Emily, would you like any comment on procurement?
Yes, thank you, David. So as you know, DHSC has been focused on 5 different areas of supply through the pandemic. The one that you specifically asked about on PPE, the PPE strategy for this part of the pandemic was published 2 days ago and outlines the substantive stocks that have been built up of all of the core items of PPE, as well as the additional resilience the UK now has because of the additional manufacturing that's now in place. So pre-pandemic, UK only had about 1% manufacture of the items used in terms of PPE, and now the capacity is up to 75% overall, which is a huge amount for some items and then less for some others where manufacture will continue to come from abroad. And most of that stockpile is already in the UK, so it's not a concern in terms of transport, etc. That have been some questions asked about. But I'd refer people to read that document, which has the detail. And of course, 2 days ago, we had the report published by the National Audit Office on the supply of ventilators, similarly, which shows there are substantive reserves of ventilators should they be required in the more challenging scenarios for this winter. And the other areas around medicines, for example, and non-clinical goods and services, there have been similar lessons learned from the earlier part of the pandemic that have been implemented in building up stockpiles and also just broad supply chain resilience in terms of relationships with manufacturing, etc.
Emily, thanks very much for that. That's great. So shall we move on to Simon? Unless you've got anything else you want to just add at the end of that, shall we move on to the sort of winter and the operational side? I'm going to ask Amanda, who I can't see at the moment, but is here.
Thank you. So look, that conversation is a great introduction actually to the paper that we've put forward here, which is covering both arrangements in response to a potential second wave of COVID, a comment in a bit of detail about particularly the planning over winter, and of course the work to restore non-COVID services that's been going on. So thank you for that introduction. I think just stepping back, Simon mentioned that back in July, when he and I wrote out to the NHS, we talked about this window of opportunity, and colleagues have also quite rightly paid tribute to the extraordinary efforts of colleagues across the whole of the NHS, not just in that first wave, but really over the last few months as well, because actually what we've seen is people have really stepped up to take advantage of that window of opportunity to restore and recover the non-COVID work. And what that means is, as Ian has said, we are back to pre-pandemic levels of activity in primary care. As Steve says, there are certain things that the NHS, of course, has never stopped, so cancer care particularly. But on those areas that we know we had to make some difficult decisions back in March to pull back on some of the pure elective work, we are now on track to deliver the ambitions that we'd set out to get to, somewhere close to sort of 70% in August, 80% in September. So I think it's a huge reflection on, again, comments that my colleagues have made about actually how much people have really worked to get round what is actually, I think we all have to recognise, really quite difficult sets of circumstances, both in terms of confidence in the public to continue to use health services when they need it, making sure that we're absolutely relentlessly applying the infection control measures to keep patients safe as well as keep our own staff safe, and also making sure that everything we then do, whether it's COVID care, non-COVID care, we do safely. And that, I think, has been a real success story over the last few months. So just to add my voice to others on thanking colleagues for all they have done. As we look forward, I think let's be clear though, winter always does bring challenges, and there's no doubt that if we now think about the rising numbers of cases of COVID that we're seeing, that presents additional challenges over above what we would normally face at this time of year. Absolutely clear that we are determined to maintain as much of the non-COVID activity as we safely can do as we head into winter. Determined to continue to be open for business, as Steve has already said, but absolutely determined to do all of that safely, and absolutely determined to support a magnificent effort over the last few months to do this, to support each other, to support our colleagues, to do what we can nationally to support colleagues out on the front line and supplement exactly the sorts of efforts that we're seeing, across the whole NHS around making sure that we have the right staff, the right skills, the right support in place as we head into winter. So I won't say any more. I mean, I hope the paper sort of speaks for itself in terms of the detail, but I think perhaps if I just hand over to Steve, who could just talk in a bit more detail about where we are and plans going forward, and then to Pauline, particularly to pull out some of the particular detail around winter planning, if I may, Chair.
Thank you very much, Amanda. Steve.
So I don't think I've got a tremendous amount to add to what we said already in Simon's introduction and in Amanda's introduction to the paper, and I'll pass over to Pauline in a minute. A few things that I might highlight. So I think on vaccination, so it's clearly going into winter where we see flu and other respiratory illnesses, and so this year the flu vaccination program is a really critical part of what we're doing, and we and colleagues across the NHS, community pharmacists, etc., putting a huge amount of effort into delivering those that flu vaccine program. It's important to remember that that is always a program that lasts from September up until Christmas, and that we roll out vaccines, and so vaccine deliveries come during that period, and GPs and others will be scheduling clinics. There is adequate vaccine in the supply chain to make sure that happens. We have not heard of any manufacturing delays, etc. But it's really important that over the next few months people do come forward, and I know the public is already responding tremendously to this, to get their flu vaccine. The flu vaccine is effective. It's a really important way of reducing flu during the winter, and of course there is clinical evidence that flu and COVID together are particularly going to have a poor outcome. So we urge people to get that flu vaccine, but know that it is a process that will occur over the next few months. And of course, we're all hopeful that a COVID vaccine will come forward, and there are many vaccines in development, some of which are further ahead than others, and we need to be ready to assist in the deployment of that once the clinical trials are finished and the appropriate regulatory approval has been granted. But vaccination, I really want to highlight, is a real particular focus of all of us this winter. And also just on that, I'd say for our staff, it's particularly important that our staff are vaccinated against flu this winter. I've always felt that is a professional obligation. We are obligated. It's quite clear in the GMC obligations and professional guidance for doctors that protecting patients, protecting yourself is important, and flu vaccination is a key part of that. So that is really very important that our organisations work together to ensure that staff are vaccinated against flu this winter too. Pauline, shall I hand over to you for areas?
Just before you do, Steve, just before you hand over to Pauline, could you just give us a view of the difference between now and, say, over the last 6 months of the treatment that patients with COVID would receive coming into hospital, in terms of what we've learned over the last 6 months?
Yes, so we have learned some very definite things through clinical trials, and Simon has referred to this already. So the most obvious one is the use of steroids. And dexamethasone was the first of those. that was identified through the recovery trial that is almost unique to the UK, and I think one of the great advantages of the NHS and that this sort of health system is that we can rapidly and flexibly put in clinical trials that produce results which are validated through the trials process, and that's exactly what's happened. And of course, that's not just benefiting NHS patients; it's benefiting patients throughout the world, and especially because steroid therapy is a cheap, well-established therapy, so it will benefit people in poorer countries as well. So that is a great achievement that the NHS has been able to facilitate with our academic partners and National Institute of Health Research. And of course, the recovery trial is still ongoing, and I would urge my colleagues across the NHS to encourage people to participate in those studies, because there is still potential to get further research information out of that study. It's also true that outside of those trials, clinicians get used to dealing with diseases and new conditions and new viruses and new infections. And we can certainly see that over the last 6 months, we have learned an awful lot about how you manage patients, about when you ventilate patients if you need to, about the sorts of ventilation you use, so-called non-invasive ventilation, which doesn't require an anaesthetic, and I think you can see that reflected in how practice has changed and continues to change. And of course, there's an international dimension to this, so we don't act alone in this. Across the world, there are studies, there are reports that our clinicians, as they always do, are referring to, are looking to, are participating in the work behind. And I'm confident that as we go forward, we will learn more about this infection, and so for instance, in areas such as the longer term consequences, long COVID, we are learning about that at the moment, and our job in the NHS is to respond rapidly to the needs of patients as the evidence accumulates and we learn more about COVID.
Thanks very much, Steve. So, Pauline?
Thank you very much. So just following on from what Amanda and Steve have said, in the paper, I'm just going to focus for a minute on section 2, which is around winter operations. And as you can see there, we've set out a number of work streams that are important for the coming weeks and months. They include the work that Steve has already referred to with regards to staff vaccination. We refer to the re-establishment of our winter operating model to support emergency care. That's something that we have now been doing for a number of years and will be all the more important during this period. We also refer to the work that we're doing as far as transformation is concerned, both for emergency care and elective care. And again, that being increasingly important as the days and weeks go by, but also ensuring that we take on board the learning from phase 1 or the first wave of COVID, and that we implement those models of care that worked very well and how we might do things very differently moving forward. The other thing that we mention in that section is the issue around capital and the capital investment that has been made available for our emergency departments, and ensuring that those monies are spent on time so as we get maximum benefit. But I'd just like to say a few more words about testing, which is the second item set out there. Maybe first to start by saying a particular thanks to all of our staff who work in testing and pathology, etc., because sometimes these people are the forgotten heroes, and I'm sure Dido will support me with that sentiment. But we've been working very closely with Test and Trace and with DHSC, and the important thing for us within the NHS is to ensure that we continue to secure the supplies, platforms and consumables that we need to increase the amount of testing that we can do for our patients and for our staff. And if the supplies that that Test and Trace and DHSC are confident can be secured and do become available during October, and we will see a step change at the end of that month. So I think that that's very important to us, and I know it will be important to all of our patients, whether they're emergency patients, elective patients, and for all of our staff. I think much has also been said about the testing of asymptomatic staff. And just to confirm that at the moment within the NHS, we do test some asymptomatic staff and staff working in areas of high prevalence. We will be very supportive as government policy emerges on asymptomatic staff testing, and as Test and Trace develop their plans around being able to secure sufficient capacity to support that. I think that's all I need to say for today.
Dido, you want to come in?
Yes, thank you, David. I just wanted to add to Pauline's comments and to add my thanks to staff working across the country in NHS laboratories, PHE laboratories, and a variety of our other laboratories across the country, as Pauline says, often quite unsung heroes who are working quite literally 24/7 to keep expanding the testing capacity across the nation and to keep us all safe. So real heartfelt thanks. And also to reiterate, as Pauline said, this is very much a team effort as we expand the Four Nations testing capacity to 500,000 tests a day by the end of October, and to sort of thank Pauline and her team in a collaborative way that we're working together to deliver that. And it's very encouraging to see the progress being made.
Well, thanks very much, Dido. Well.
Thank you, David. Pauline, I wonder if you could say a bit more about the inevitable issues around infection protection and control, prevention and control, I should say, rather. You're on mute.
Pauline, I think you're on mute.
Yes, I think you can hear me now.
Yeah.
Yes, sorry. I'm very happy to comment. I think Ruth May will probably want to comment as well. So from an infection control perspective, I think we've worked to ensure that the service receives timely information as the pandemic has progressed. And that is clearly very important from an emergency care point of view, but also from an elective point of view, so that staff are very much aware of the precautions that need to be taken to ensure that we keep levels of nosocomial infection down to an absolute minimum, indeed, that we don't have nosocomial infection. And it's not just from a policy perspective, but we've also clearly made a significant investment. I mentioned the work around our emergency departments to try and ensure that we have the appropriate environment that supports staff in their efforts. Ruth may want to continue.
Thank you very much, Chair. So, well, we know that infection prevention and control is everyone's business within the workplace. It is of clinicians, managers, all of our auxiliary staff, everyone's responsibility. And that's why we've worked with PHE as they've published their guidance on infection prevention and control. And we've updated it as the pandemic has gone on. So as we've learnt more about the interventions that we can make, we've done that. And masks is a really good example. So when we saw staff to staff transmission, not in the actual clinical workplace, they were using PPE very, very effectively, keeping themselves and their patients safe. What we did see is in the emotional labour, the emotional challenges of being a frontline clinician in the coffee rooms, in the offices, people weren't necessarily social distancing. And that's why masks were part of our support package to staff and their guidance. I'm really proud of the way staff have supported IPC. They've had to really step up and work with this new virus. Social distancing in hospital was nothing that we've seen before. I'm really proud and I'm very, very thankful to the way that all of our staff have stepped up to do that, particularly our IPC nurses, doctors and the like. I'd like to say also that I've been really pleased about how we've worked in partnership with our Royal Colleges and our Royal College of Medical Colleges and our nursing colleges, and how they've helped us inform the next stages of our guidance. So I hope that gives you some information about what we're doing.
That's really encouraging. That's very encouraging. Thank you.
I wonder, Amanda, you just give us the board a view of how hospital groups and individual hospitals are dealing on the ground with this infection control issue from COVID.
Yes, thank you, David. So I think what Ruth and Pauline have said is absolutely spot on, and I think there's no doubt that, and I think Steve's mentioned it as well, as time has gone on, of course, we've learned so much more about this virus and about the steps that we need to take, colleagues need to take to keep staff safe, to keep patients safe. So there's been a kind of constant agility that we've been asking for in our kind of frontline colleagues to implement the adapted, new, up-to-date guidance. And real credit, I think, to the leaders, clinical leaders and managerial colleagues in how they've been able to do that, as well as Ruth says, to staff themselves, so how they've responded to it. I think what we've seen, again, what's been great is this didn't stop at the end of the first wave. What we saw in that first wave, though, was a real coming together of organisations, hospitals, in partnership with community, mental health, primary care, other hospitals, to work as in a very collaborative way, whether that was around just very practical mutual aid, or whether it was, which I think is a bit where you're driving at, actually around sharing expertise. So we've got some great examples from our regions of where people have been using peer review, for example. So rather than just relying on self-assessment around the ability to comply with infection control standards, they've been inviting in colleagues from other organisations to come and give a fresh eyes approach, offer some expertise, as well, of course, as using regional teams and national teams to assist with that. So we've seen that throughout the whole of the first wave of the pandemic. I think we've seen it increasingly now bedded in as a way of working over the summer. So as people have responded to the challenge to restore services, it's been done on a system-wide basis rather than as individual organisations working together. And I think that is as true of how people have responded to infection control challenges as it is of how people have responded to elective restarts. And it's very much, I think, what we're looking to continue to see as, I think Simon said it right at the beginning of the meeting, we see increase in COVID now, which of course is disproportionately affecting some areas rather than others. So the need to continue to have that system-wide response it is critical to our ability to continue to provide services safely over the next 6 months.
Thank you, Amanda. Look, before I hand over to Julian on the money, is there anything else you wanted to say before I do that from an operational perspective?
For me, no, I think it was really, so thank you for the opportunity. I think the message really is, the headline, as ever, the headline is actually, it's just a massive thank you, because whether that is to people working on the front line, to the leaders within individual organisations, to those working at system level, regional level, national level, it still feels like this is a huge combined effort to make sure that the NHS is open for business as it has been throughout, that we're continuing to maintain, protect the non-COVID work, but crucially now, of course, turning our attention to safely being able to respond to increases in pressure, whether that's sort of normal winter pressures or it's the additional pressures that COVID brings. And that, I think, really probably in a nutshell, David, is where I think the NHS has been, is now, and is looking to the future.
Good. OK, thank you very much, Amanda, for that. Thank you. So, Julian, where are we with the numbers?
So, as the report sets out, which takes us through to the end of July, there's been a very consistent rate of aggregate over the first 4 months of the year. Subsequent to this report, we have had month 5 numbers, which actually just continue that trend. On average, we have effectively been spending about £1.25 billion more a month than the budget planned before the start of the year. That is a combination of higher costs due to COVID as we expanded the workforce, dealt with sick absence, lower income from providers as they've had less private patient income, less visitors to hospital, changes in their research programs, a whole series of issues. The cost of the extra services, the extra capacity we have put in place through the independent sector, and the enhanced discharge arrangements that have been put in place. And certainly at the beginning of this period, actually higher levels of prescribing as we went into the kind of first phase of lockdown. But the pattern has remained remarkably constant, even as we've now stepped activity back up. I mean, you can see a change in costs due to COVID versus the extra marginal costs of activity. Worth saying that we have put out to the NHS financial envelopes for the second half of the year. Consistent with the planning for recovery that Amanda and Pauline have mentioned, we are now getting back the first financial returns consistent with those financial envelopes, and we will continue to track how that works through over the next month. I should probably stop there and just take any questions.
Thank you very much, Julian. Anyone on the board have any questions for Julian on the numbers? Wal, you're as chairman of the ARAC. Do you have any questions on the numbers?
Actually, I don't. It's a very good paper, Julian. Thanks. Very clear what's happening. Perhaps just one. How comfortable and confident are you about the balance of incentives to continuing work in the electives and non-COVID area versus the fact that we're having to sort of address COVID? How comfortable are you that the balance is right?
I think, as kind of Pauline and Amanda has said, you really do, we have really seen over the last couple of months the service work incredibly hard to step activity back up while still dealing with some of the issues around infection control. You still see it now, even as some of the sick absence has sort of ticked back up. So it's a massive challenge, but you can really see the service responding to recover. Clearly there's going to be a challenge as we go through this next phase, depending on what happens to the pattern of COVID. But I think, again, you can see the plans coming through to where the service is really thinking hard about how it uses the capacity it has available, the independent sector, where people are thinking of switching, particular pathways, for example, into the independent sector to protect them as we depending on what happens to COVID in local systems. We have put out there a financial incentive scheme, not without some controversy. But again, I think you can see the service responding and doing, absolutely working flat out to recover those services.
Thank you, Julian. Any other questions on the first 4 month results? No? Okay, well, thank you. So the next item is an item very dear to my heart. And so, Ian, you've done a fabulous paper on this, on getting to net zero carbon by 2040. Would you like to introduce the paper and introduce Nick Watts as well? I think it's just Nick, you've just joined us, I think.
I have, I'm here.
Ian, over to you.
Great, thank you, David. So we protected this work fully during COVID, and as a result of that, we can today set out ambitious goals. These have been warmly welcomed by the World Health Organization. We intend to use our leadership not just to look at what's directly within the NHS's gift, the NHS carbon footprint, but also how we can influence our supply chains, including, for example, medicines. The goals in the report are as informed as they can be by the evidence. We had an international call, extensive engagement, consideration of different interventions, and a hell of a lot of detailed modelling of all the different effects. The report marks a major step, but of course it's not the last word. It couldn't be in this arena. We're inviting feedback and welcome further suggestions, and wherever it's credible to do so, we will go further and faster. I'd like to highlight the last mile problem, the challenge of getting from 80% reduction to 100% reduction. This is very significant in this area, and that's why we have developed ambitious earlier goals for 80% reduction as well as the net zero goal. Prior to COP26, the UN conference that the government will be hosting next year, we'll be working incredibly closely with government so that the NHS can take a central role within the government's greener agenda. And my final observation is, look, as we're focusing on delivery, I do think we can take some comfort from our track record in this area since 1990 and the progress we've made against our Climate Change Act commitments, and also the huge energy and enthusiasm we see of frontline NHS staff to participate and progress this agenda. We're strengthening our own capabilities under Nick's leadership. So Nick not only has chaired the panel and been the executive director of the Lancet Countdown, he is now joining us full-time from the 26th of this month as the NHS's Chief Sustainability Officer. And we have a lot of input and support, fantastic support from teams across NHS E&I, including perhaps most obviously Emily's teams working on estates and also on supplies. So I will turn now to Nick to take us through the item. But as I do so, I just want to say a big thank you, Nick, to you for your personal leadership, to the Lancet Countdown for all the resources they've provided gratis in some instances to help with this work, to my team and indeed panel members. Nick.
Indeed, thank you. The thanks doesn't go to me. The thanks goes to the team at NHS E&I that have really been working behind this. It has been incredibly impressive. The thanks though also goes, Ian, to yourself, to David, to Simon for your support. Everything that you're going to hear, I'm only going to take 5 minutes. Everything you will hear has taken place over the last 9 months while the NHS has been responding to COVID. So everything that we're discussing and everything in the report that's been sent there is designed with this in mind. It is conscious of the pressures, conscious of the response of the system, and conscious of ensuring that as we work towards delivering a net zero health service to respond to climate change, it's also done in a way that is good for patients, good for public health. So I'm a doctor by training. Work on the links between public health and climate change. Worked with the WHO, with the Lancet, with University College London. I spend my life working with an enormous amount of data, and three very, very clear things are apparent when you look at the data. The first thing, the human symptoms of climate change, they are unequivocal. They are affecting the health of the British public today and right around the world. Secondly, at the global level, not enough has been done. Not enough has been done to respond to this emerging health crisis. And thirdly, that response, where it does exist, it is fundamentally good for public health. And there are glimmers of hope and reasons for optimism. And I think the thing I'd like to start with is that for the last decade or so, the NHS in England has always been one of those reasons for hope. When we look around the world at the response to climate change, the rest of the world, it looks at the NHS with great admiration here. New information in this report where we re-baseline the carbon emissions of the health service. We see for the emissions that we directly control, a 62% reduction in emissions. For the entirety, for the emissions we control, as well as those we influence in the supply chain, a 26% reduction. These are very impressive. They are in line, they exceed the commitments under the Climate Change Act. So it's with that we build on this net zero plan. It's the result of 650 submissions, over 650 submissions to a call for evidence. The team of analysts we thanked, guidance from an expert panel. It builds on that and it answers a pretty simple question. What is the fastest, what is the most credible date that the NHS can reach net zero carbon emissions? And so the answer there for the carbon footprint, which is the emissions we control directly, is 2040. This is the earliest, this is the most ambitious, but still credible. To make sure that we have near-term goals as well, we have an ambition to reach an 80% reduction by at the very earliest 2028. But as Ian said, we take full accountability for the entirety of our footprint and profile. And so we've developed a second target called in the paper the Carbon Footprint Plus. This includes all of the emissions we influence as well as those that happen on site in the delivery of care. And the air, we think we can reach net zero by 2045 with an ambition again to reach an 80% reduction by 2036 at the very earliest. So the report lays out all of the modeling for this. It lays out the interventions behind it. It lays out the thinking. It describes the pace, the scale, and the scope of change we think that is needed. But most importantly, I think it describes three key elements that we need to make sure that we are successful. So firstly, it's important that we get started now. It's important that there are early commitments to make sure that we demonstrate the NHS is serious, that it's credible across our entire emissions profile. And you will see reference to new hospital standards for net zero hospitals. You will see the launch of a new national Greener NHS program, and you will see every single part of the emissions profile of the NHS with work to do. The second thing it has to do, it has to lay out some of those interim targets, and it has to launch an iterative and adaptive process. 2045, 25 years away, is a long way away, and we don't have all the answers right now. We are committed to getting to that end point, but we are aware that we will have to come back again and again. And so in line with the carbon budgets of the United Kingdom, we'll come back and reassess, look at how technology has shifted, look at how clinicians, how staff, how the NHS has responded to this challenge, and where possible, where practicable, increase our ambition. Finally, the third thing that this needs to be a success is this is just a report. It needs the support of all 1.3 million of the NHS staff, and it needs the support of each of you in order to be successful. We know from a recent survey that 98% of NHS staff support the health service taking further action on this agenda. We also know that over the last 10 years, and from a wealth of scientific literature across the world, actions to respond to climate change, they are fundamentally good for health. They result in cleaner air, they result in healthier diets, they result in more physical activity, safer communities. Much of what we're talking about here will improve patient care, it will increase efficiencies, and it will prepare us for the future. And so with those three things in mind and the launch of an engagement process over the next 6 to 12 months, I look forward to the discussion over the next couple of minutes, the time we have left. The targets and the commitments here, they are credible, they are ambitious. They will ensure the NHS is able to continue to deliver high quality care for all, both today, but well into the future. Thank you.
Nick, thank you very much for that. And I mean, it's a very exciting programme. David Roberts, you have had an interesting perspective on this from a staff point of view.
So I've got a perspective, and then if I may, a question. So my perspective is, I think this is, so the places I work outside of the NHS, this is vital, because actually, if you don't respond to the climate emergency, then your people will slowly but surely lose confidence in you. And actually, from a recruitment perspective, from a retention perspective, from a motivation and morale perspective, all of those things mean that we don't have an option to engage our people, support them in following the actions and following through. So I think this is an incredibly powerful platform across multiple stakeholders. My question, Nick, is the other thing that the other places I do, scope 1 and 2, broadly within your control, you can access it. Scope 3, really, really hard. And therefore, the question for you is, how credible is there only to be a 5-year gap between scope 2 and scope 3, given the challenges for scope 2?
Yeah, that's right. You're picking up on a crucial issue there about direct control and sort of emissions we can influence. Part of what makes that 2045 ambition there credible is that the rest of the world is moving with us. We are seeing all around the world, countries, companies, communities bringing forward their own net zero commitments. And as we do that, supply chains will decarbonize along with us. And so this is in line with the direction of travel for the international community. And that's what helps it. We are moving ahead of that, and we are pushing the curve there. But it is that joint commitment that helps us get there. This is the NHS's sort of role in that leadership. In terms of the 5-year gap between the two, I suppose the reason that is credible is because of the Paris Agreement, because of how powerful that international agreement is. It's actually what the WHO has called one of the most powerful public health treaties of the last century. That sets us on that trajectory as well. And again, as the world comes to COP26 in Glasgow in 2021, we think that in response to this commitment, we will start to see other health systems. We hope we will start to see other health systems move with us.
Okay, and you've seen China and others giving leadership recently. Yeah,
indeed.
Okay, thank you, David.
Emily, clearly your responsibilities for both property and the supply chain are going to be crucial to this. To what extent are you really involved in this project?
Thank you, David. So Ian's team or Nick's team rather, and my teams are working very closely together on this. So in two key areas, but there are several mentioned in the paper. The first is on the whole supply chain piece. We're obviously also working closely there with DHSC and NHS Supply Chain, who hold critical parts of the supply chain, to make sure that this is engineered throughout our commercial activity. And the second is in our infrastructure management. So part of that's obviously with NHS Property Services and Community Health Partnerships, but part of it is with trusts and with other healthcare users. So the big opportunities include how we approach the 40 hospitals programme, the infrastructure programme, but also some of the other infrastructure investments that are being made in the short term, for example, addressing the mental health dormitories position. And so the numbers which are in the paper, particularly the helpful chart with the curves that shows everything we have to do to get to net zero, includes the expertise of those teams as to what can be achieved over this period.
Thanks, Emily. Well.
Thank you, Chair. The hospital infrastructure is not homogenous in the sense that urban settings versus rural settings or less heavily urbanized settings. And I've heard it described that in very urban settings, the hospitals are the modern equivalent of factories in the centres of areas, generating pollution, traffic emissions. Have you thought about the pace at which you can affect the existing infrastructure as opposed to the new hospitals being built? And by the way, fantastic report, unbelievably great. The NHS is leading on this.
Thank you. A good question. Yes, we absolutely have thought through this, and if it's helpful at some point, we can provide the detail attached to that. It's important that we are able to decarbonise not only new infrastructure, you're right, but the existing estate. I think the issue that you picked up on there is probably exactly why we think this is going to be positive. Great Ormond Street Hospital in London has a fantastic example of shutting down every now and then its roads, letting kids in the hospital come out, play, enjoy the space. That's great for them because it gives them a bit of space outside the hospital. It's good for air pollution as well. Drastically reduces air pollution, and we know the 30,000, 40,000 deaths every year that happen as a result of that. So it is exactly those health benefits that come from decarbonising the existing estate, particularly in highly dense urban settings, that I think gives us the confidence to be able to do that. There's a lot of work to do there, though. The NHS has a big estate. Thankfully, it has the workforce, exactly as you said, David, that I think will be behind this to help deliver it.
Thank you, Munir.
Thank you very much. A fantastic report and fully supportive. As you said, it is affecting public health right now, and we need to do something about it. I just want to, and you rightly have highlighted the importance of research and innovation. That may be really important to get the last 20%. I wonder whether you can elaborate on how that will be important.
Yeah, this is that last mile problem in part that Ian helpfully alluded to. We must always keep that in mind. The approach you have to take, I think, the approach at the international level for reducing emissions and hitting net zero targets is you must reduce your emissions as far as you credibly can. And then you must reduce them just a little bit further. And then you can start to consider what we call negative emissions. And this then is where you start to look at ways that we can take emissions outside of the atmosphere. So there is a thing called the NHS forest. We know that access to green space improves mental health. We know that it's good for physical activity. We know that it reduces noise, air pollution. Those sorts of interventions are the kinds of things available to us to access some of those negative emissions. And then on top of that, there is the research and the innovation space there. There will be technologies that do not exist today that we can't even imagine, but they certainly will be there going forward. Now, the reason we know this, or the reason I have a little bit of confidence in saying that, is that we have seen this happen again and again. We have seen targets in response to the 2008 Climate Change Act move forward again and again as technology evolves. Previously, it was unfeasible the idea that electric and non-electric vehicles would be at cost parity until the mid-2030s. That's already happened. That technology advanced rapidly, and so that's the kind of research and innovation that I think we expect to see and hopefully expect to lead.
Thank you.
Thank you. Ruth.
Thank you very much, Nick. Great, really energising and exciting stuff. So thank you very much for the work that you're leading. I know that my profession, the biggest workforce in the NHS, would be really behind this, and I'm sure we could provide you and give you some experts to join your expert panel as well, so that nurses can make a contribution at all levels through the next stages of that. Look forward to working with you, Nick.
Excellent.
David, that wasn't a question, but do you mind terribly if I quickly respond?
Of course, go ahead.
Ruth, thank you for the offer. We would love the help. Nurses across the world, but especially in England, have led the charge in the response to climate change. The work of the Royal College of Nursing is incredibly impressive, the work of the profession across the different trusts. So I think we are fully aware of that and would welcome any help you can provide.
Look forward to it, Nick.
Good. Simon, you're going to have a last word on this, I think, please.
Well, thank you, Nick, and thank you to the entire 600 plus people who've responded to your call for evidence and all of the staff across the health service who've led to this. I thought maybe, David, just to summarise 3 key points that I think came out of the conversation. The first is that, of course, 2020 has been dominated by coronavirus. That is the highest immediate priority and pressure on the health service, as we all know. It was just sort of a bad luck for Nick that it was a week after his work was commissioned that WHO declared coronavirus a global health emergency. But the reason we feel that we have to do both and is that looking out not just now, but over the medium and long term, it is clear that the evidence shows climate change will be the biggest threat to human health in the way that Nick has described. And the second thing that follows from that, of course, is that the NHS is both part of the problem as well as potentially part of the solution. We are the biggest employer in the country. We are perhaps 4 to 5% of in this country. And therefore, if the UK is going to meet its legally binding climate obligations, the NHS is going to have to continue to step up. And I think the point that Nick makes about the international aspects of this are particularly significant, because to the question that David Roberts raised, actually we're going to have to catalyse changes across the healthcare supply chain, including the international pharmaceutical sector. And that's one of the reasons why it is particularly welcome today that the World Health Organization, the Director General, Dr. Tedros Ghebreyesus, has specifically come out and backed the work that the NHS is leading, thanks to Nick's report, because that will help catalyse some of those international partnerships with our shared supply chains. And then I think the third thing to say is that there will inevitably be a debate about, on the one hand, the credibility of the stretch targets that have been set here, versus on the other, whether or not we can go faster. And the whole point of having this laid out in such a detailed way is so that we can actually have that debate, we can mobilise support, and we can continue to deepen ambition. So I think these are a set of firm commitments we're seeking to enter into, but this will be an ongoing process, and by no means is today the final word.
Thank you, Simon. So, Nick, you got the total endorsement of the board and huge enthusiasm from us all, and so all power to your elbow.
Thank you. Thank you, everyone.
Thanks very much, Nick. So the next item is diagnostics, and I'm very pleased to welcome my old colleague, Mike Richards, back here, who's done this outstanding report on diagnostics. I can't see you yet, Mike, but are you here? You are here. And good, because when we last spoke, you weren't feeling terribly well. So anyway, you're here and with us, which is terrific. So would you like to present your report?
I would be very happy to do that, and thank you for inviting me, and thank you, Simon, for commissioning the report. First thing to say is I'm not going to go through it in detail because you've all had it, but it is deliberately broad in its scope, covering imaging, endoscopy, pathology and physiological measurement, and some aspects of genomics as well. I think you will all know that diagnostics is really key to many areas of healthcare, and indeed to the commitment in the NHS long-term plan. The problem is that even before the pandemic, diagnostics were reaching a tipping point. Demand was exceeding capacity. Demand was going up from all directions, from A&E, from inpatients, from outpatients, from GP requests. If you go to an A&E department, type 1 A&E department, 1 in 10 patients will get a CT scan, just for example. But in comparison with that demand, neither our equipment nor our workforce have gone at the same pace, and we're seeing that impact both in terms of waiting times increase, but also the need to outsource imaging, image reporting, endoscopy, and indeed some aspects of pathology as well. And you will also have seen from the report that if you look at our international comparisons, particularly on CT and MRI, when we've got OECD data, we are right at the bottom of an international league table. So that was the position before COVID. With COVID, you will all know that throughput has been reduced, and we've heard about IPC issues in this meeting this afternoon. The backlogs have built up, particularly with endoscopy. The pathology staff have been working really 24 hours a day trying to do the testing, and COVID itself has had an impact. For a start, we've seen the impact on mobile chest X-ray machines, which are needed on intensive care units, showing up the fact that a lot of our machines are well past 10 years old. And we've got the new problem of long COVID with respiratory problems, cardiac problems, etc. So that's all the challenges. The report, not surprisingly, says we need to increase capacity. That is, we need to have more machines and facilities, we need to have more workforce, and alongside that, we need to have the training to get the workforce. So there are both capital and revenue implications. But as much as that, we need to do things differently. And the key recommendation in the report is that we should separate what I'm calling acute diagnostics from elective diagnostics. So acute diagnostics being the diagnostics needed by the A&E department or the inpatient wards, where whatever the test is, it needs to be done either within the hour or within the day. Whereas elective diagnostics coming from outpatients or from GPs needs to be done within a matter of days or a week or two. So separating those two, but then the next question is, if you're then having to build up the elective capacity, where would you do that? And the recommendation is that we would do that away from acute sites in general. That will promote convenience for patients. I think if it's done well, it could contribute to net zero as well. I think it will undoubtedly improve efficiency in terms of throughput if you're not having to mix the acute and the elective patients all the time. It will be easier to keep things COVID-free. And incidentally, it is less expensive to build on a non-acute site than on an acute site. And so all of this is what we're referring to as community diagnostic hubs. Those hubs need to be linked, of course, both to hospitals and to primary care. So the IT elements of this are vital. And we need to get, whether it's imaging people or pathology people or endoscopy people, etc., working together in networks, which could very easily be at the level of an ICS. Of course, we also need to look at new diagnostic technologies. AI is coming. We're probably going to see it first when it comes to mammography and mammographic screening. I don't think it's immediately going to get rid of the need for radiologists, for example. I do think over time they will be doing relatively more invasive interventional radiology and less time probably spending in looking at X-rays. We also need to look at point of care testing and wearables, but those will all come, so we need to prepare for those. To drive the changes that I am recommending, it's going to need leadership. I am delighted that NHS England and Improvement have already set up a diagnostics program board with Steve Powis and Hugh McCarthy co-chairing that. We've also got a workforce board in operation, had its first meeting this afternoon, and we will need regional involvement and local involvement as well. And that's already beginning to happen because diagnostics have frankly come to the top of the agenda as a result of COVID. So the benefits of all this, first and foremost, there will be improved outcomes for patients, and it will make a big contribution towards achieving long-term plan commitments, such as the commitment to diagnose 75% of cancer patients at stage 1 and 2 by 2028. So benefits for patients. Benefits in doing this in a planned way. If we bulk buy the equipment we need, we will get substantial reductions. We've seen that in the past. By getting the imaging done in a sensible way across networks, we will avoid duplication of imaging. We will reduce the outsourcing, which is costing us about £160 million a year at the moment. There will be the efficiencies of streamlining. We can really drive skill mix initiatives. And in the acute sector, we can promote same-day emergency care by getting the scans done more quickly. And in terms of inpatients, there's really considerable potential to reduce length of stay. We know that a lot of CT scans and MRIs are not done on the day that they're requested as inpatients. They may not even be done the following day. And all of that leads to longer lengths of stay. So all of that, I believe, there is potential to really improve outcomes and have efficiencies too. I'll stop there.
Thank you very much, Mike. Steve, did you want to comment on that at all? Steve Powis?
Just briefly, as Mike has said, and as the paper says, Hugh McCarthy and myself, Hugh's not here, I think, co-chair a diagnostic board within NHS England, NHS Improvement. We've been working closely with Mike as the report has taken shape and have considered the report at several meetings, and I just want to confirm that we are very, very supportive of the work that Chris has done, that Mike has done, and the report.
Thank you, Steve. Dido?
Well, Mike, thank you for a really excellent piece of work. It's fantastic and really exciting. Just a question. I wondered if you would talk a bit more about the digital elements in the report and how you see this as a means of making a big step forward in patients having ready and easy access to all their own test results and making those more portable and easier for us as citizens to use.
Thank you, Dido. The plan to digitize all of this was actually in an imaging policy and in pathology policy already. It just hasn't had the capital that is needed to make it happen. And I think we now need to drive that. I think that will enable hospitals to communicate with each other, community diagnostic hubs to communicate both with hospitals and with primary care, and absolutely no reason why that can't also include including patients themselves having access to all of their own information. So that to me is a critical element of all this.
So, Mike, if you were to sort of gaze into the future, with a genomic future, with point of care saliva testing and wearables and sensors, everything else, are we going to need doctors at all, do you think?
Yes, David, we are. I don't know if I need to say more than that. I think the human element will be there. Of course, technology is going to assist us. It is assisting us all the time now, but I don't think, I wouldn't be worried for members of my own profession that they're going to be out of a job for a very long time to come.
I thought you'd probably say that. I too happen to agree with you as well. Ruth?
Thank you very much, Mike. Nice to see you again. Great report, and good to see the focus on this particular area of care for all of our patients. Your recommendations 14 and 15 around needing additional staff, I think for me it's about how people work as a team, how we have all sorts of people from different backgrounds opening our eyes about how each one of us can work very differently to be in a team. And I think that's the big thing that I've personally learned through the COVID, is actually we've widened the team out from all sorts of different specialities to care for our patients. And I'm hoping that through your work now that we can further build on that, so that we're looking much more into team approach rather than just one professional or another.
Ruth, I completely agree with that. And I think we do need to learn from the experience with COVID and the things that have happened really very quickly as a result of COVID. Let's make sure that that now happens and is carried forward with diagnostics. Yes, I think teamwork. If you take imaging, I think that we need to be looking at a skills escalator, bringing in people who may be out of jobs from other sectors immediately, who can come in and they can then go up the skills ladder over time. I think we really need to push the skill mix agenda. We've pushed it in certain areas of diagnostics. 15 years ago, we pushed it in breast screening by bringing in assistant practitioners. That took an awful lot of hard work to get that to happen, I know, to my certain cost, but it was possible. But we haven't extended that to other areas of diagnostics. We now need to do that. I think in endoscopy, if we have good working between endoscopy nurses as well as the endoscopists themselves, and of course some of the endoscopists are nurses, that can make a difference as well. And we have that in the screening program, but we don't do it in symptomatic colonoscopy. Don't ask me why. So there's a lot we can learn.
Thanks, Mike. Tim Ferriss.
Thank you, David. Professor Richards, your paper was terrific, and congratulations to the team. I'd like to if I were to reflect on how I would approach doing something that is absolutely necessary and much better patient care, something that, as you're laying out here in your paper, in the United States, I expect I would encounter an extraordinary amount of resistance from the professional societies. And I wonder if you might comment on sort of the downfield blocking and challenges that your plan will face here in England.
Tim, I think there are some really interesting comparisons internationally. So, for example, with our community diagnostic hubs that we're recommending, an awful lot of other countries do diagnostics much closer to home than we do. They don't do it all on acute hospital sites. In terms of the professions, I think sometimes there may be advantages in being in a very acute situation where we desperately need more staff. We're not going to get more doctors to do everything like this. And, I'm an oncologist by background. I remember the days when it was doctors that gave the chemotherapy. Thank God that. And now it is taken for granted that is not done by doctors. So I'm really pleased that we can push that. I think we've shown it with nurse endoscopists already. A lot of our flexible sigmoidoscopy, a lot of upper GI endoscopy is already done by non-medical staff. So, we can be leaders in the world in that. And that, yes, there might be more resistance in the United States than there is here.
Great, thank you.
Ian?
So just on a primary perspective, Mike, I think your report will be hugely welcomed. There's been massive pent-up appetite for decades for primary care to be able to access a larger array of diagnostics in the community. And there will be an enormous appetite both for primary care networks and community providers working really closely together as part of our integrated out-of-hospital delivery systems to help be part of the solution in delivering the community diagnostic hubs. And then just connecting this back to the conversation we were having around estate. as we think not just about the future hospital build programme, but actually the modernisation of primary care estate. I know Emily's team have been doing fantastic work on what the blueprints look like for new integrated primary and community facilities, of which diagnostics will be an important component at different tiered levels.
Ian, absolutely, and we have been talking closely with primary care colleagues throughout this. It reminds me to say one thing, which is about phlebotomy services, which often get overlooked. In some parts of the country, you can get phlebotomy done in primary care 6 days a week. In my own practice, I can get it done half a morning a week. And otherwise, they expect me to go to an acute hospital, which is not the right thing to be doing at this stage. We need to improve our phlebotomy services. And the more we move outpatient work out of hospitals, the patients are still going to need blood tests. So there will be more work to be done in the community. So I would ask people to really take an interest in that particular aspect.
Thanks, Mike.
Mike, can I just come back briefly on that, just to say,
yeah,
I couldn't agree more. That, again, COVID in particular has emphasised the weakness of the fact we've never had a comprehensive phlebotomy service in primary care. And it's really striking how, as you say, in some parts of the country, e.g., if you look at Tower Hamlets, you have a far bigger volume of phlebotomy that's actually happening in the community already. And I think the trick is, how do we use your report as well as activity already underway linked to COVID to try and achieve that goal?
And I've talked to Sam Everington too.
Right. Patrick.
Thank you, David. Mike, this is wonderfully clear and logical report. Thank you. It was a delight to go through. I wanted just a couple of points you might expand on. First of all is AI, the Chiron sort of collaboration. Could you give some sense of the speed at which AI will impact both radiology and pathology, particularly in histopathology, something you've picked up on?
Thank you very much for that, Patrick. I think it is moving. It's moving in imaging. It's moving in pathology. It's moving in endoscopy too. I think, as I said, mammography is almost certainly going to be the first, partly because in breast screening we currently have 2 humans looking at every single image. And I think where we will move first is to replacing one of the human readers with the machine. But it's got to be done well, and it's being tested. And there are big, large-scale studies of that going on in the East Midlands now, for example, and with others. I think chest X-rays may come next, but they are complicated because the chest X-ray does not just have lung, it has ribs, it has heart, it has all sorts in it. And the same is true with CT scans of the chest, which extend down and cover part of the liver and the spleen and goodness knows what. So they're coming. They will probably be most useful for triaging. This one is very, very low risk. This is a very high risk. Can it be looked at by a radiologist most quickly? The real point where it gets interesting is, can we say this is so low risk that it doesn't have to be reported by a human? I think with histopathology, the first step, Patrick, is that we need to digitize histopathology. If we want to be able to do the AI, we've got to have this not just on a glass slide. We've got to have it properly digitized. And I think then it will come in first, probably for small biopsy samples, the polyps taken out of the bowel screening, or prostate samples, etc. I certainly think it will come in there, but let's get it digitized first. And I think in endoscopy, it's exciting, but what is exciting about there is it may improve the accuracy of endoscopy, not necessarily the speed.
Thank you, Mike. Amanda, I mean, from all your experience of running big, acute, integrated hot and cold hospitals, how do you see community diagnostics?
Thank you. So I was debating whether to come in or not without just sounding sycophantic, because I do think that this is a really super piece of work, and particularly because what it does is recognise the importance of seeing diagnostics as a whole rather than just individual specialties. individual modalities. So I think it's and as other colleagues have said, actually one of my very first jobs was as a general manager looking after diagnostic services and in fact outpatient. So it's just great to see some of those services that sometimes don't get the attention absolutely elevated to giving those sort of then getting right at the top of the national radar in the way that I think they now have and they need to. So certainly I've been involved in setting up community diagnostic type hubs before as part of different models of care over the last sort of 20 years. And I think where they work well, and particularly now that we're in a sort of with COVID world, you can see that they are going to be, I think, phenomenally effective at providing really efficient, really patient-centred, really easy accessible services. And if we can get the wraparound on workforce, which colleagues have mentioned, on the digital AI side and the physical location to come together, then certainly from my perspective, I can see why this has been so widely welcomed, not just by Royal Colleges, but by all of those people who've been involved in this work so far. And I'm extremely keen to support us to take this forward.
Thank you.
David Bean, did you want to raise any issues around workforce issues? No, David. Is David dropped off?
Yeah, no, I'm with you. Thanks. No, I think this is, like others have said, a hugely important report, and knowing Mike as I do, it's not surprising. I think what it's challenging me to think about, though, is both it's articulating the demand for staff in diagnostics, and I think a lot of thought now needs to be given to the supply of staff. Where are they going to come from, and whether the training pipeline is factored in, and I think that's work still to be done. So I think the Diagnostics Board has some important work to do to actually begin to give action to some of the recommendations that Mike has made, but hugely important. I'd personally echo the issues around skill mix, around the use of technology to support the delivery of these recommendations. And that's where some of the conversations elsewhere on our agendas talked about the transformation agenda. And I think the report of itself, using some of those technologies, digital AI, etc., can be transformative in the way that we provide these services. But key issue for me, David, is to just think through what the workforce supply is. If this has articulated the demand, what's the workforce supply that we can begin to grow over this next period of time? Thank you.
Thanks, David. Noel Gordon, sorry, I can see. No, I didn't see you, sorry.
Thanks, David. This is a really practical report, Mike, and it's practical in the sense that many of the building blocks which would allow us to implement this are more or less in place. And I'm particularly thinking of the technology infrastructure around messaging, imaging tools, patient records. I mean, a lot of that is there waiting to be leveraged. And you alluded to pilot sites, and I'm thinking of MRAD in the East Midlands, which of course is one of our pioneering sites for centralized hubs. The question is more around what can we get on with in the short term, given how important the renewal element is and the recovery element post-COVID, as it were. What do you think we can start doing in the next 6 months that will get us some way toward your vision, given that a lot of it might require capital funding?
No, thank you. I think the simple answer is that the NHS is getting on with this. We have been feeding elements of this report through to the regions and sub-regions for some weeks, if not months now, in response to COVID. I think that's why I'm so sure that there is a positive response here. Regional colleagues and others have been coming back to us saying, let's move as fast as we possibly can. We have a diagnostics recovery implementation group that is actually driving this. I think we can only go so far. we have what's called an Adopt and Adapt program, which is leading on this, but we do need the capital in the first place to start getting some of these community diagnostic hubs up and running. So I think the NHS is really wanting to drive this and is going as fast as it can, but yes, it will need the capital to get the community diagnostic hubs and the IT infrastructure in place. Those are the two most important things. I think the workforce, which David Behan was mentioning, hugely important, and in the longer term, probably the most difficult. I think we can do a lot on skill mix quite quickly if we really want to get it done. And I'm delighted that the joint HEE, NHS, ENI board is now in action, and I impressed on them earlier this afternoon the urgency of this. But we also need to be looking at bringing new people in at the bottom end of the escalator ladder. So I think there is a lot we can do, but we will need more capital.
Julian? Julian, I think you had your hand up.
I was just going to say that I mean, we'll have to do this through the Diagnostic Programme Board. It's developing actually how we do also the funding model with systems and really getting that buy-in. And I think sort of, you know, even if there's national funding, how do we make the engagement work with the kind of right join up of funding from the kind of local and national to really make this fly and get the ownership. And I think that's one of the key things we now need to work on. And I think it'll actually be critical as we go through the spending round.
Thanks very much, Julian. Well, Mike, the risk of joining Amanda and being sycophantic as well, just on behalf of us all, thank you very much. It's a terrific report. Thank you.
My pleasure.
Good. So the next item is the public participation dashboard. Ruth.
Thank you very much, Chair. It is the start item for note. It is the work of Olivia and Neil in their teams. We know, and quite rightly, we need to consult. We have a duty to do so. Equally, we know the value of the patient and the public voice. And I just want to commend this report to you.
Good. Thank you very much, Ruth. Have we got any other business? Simon, have you got anything you wanted to end up with? No.
Nope, I think that's the business we had before us. Thank you, David.
Okay. Well, thank you all very much.